In Japan, cancer screening is not performed in manner of evidence-based approach. Screening programs without recommendations by the guidelines are highly prevalent as cancer control projects. Thyroid cancer screening is also performed. The reason for such condition is due to a lack of knowledge about principles of screening. Evidence-based guidelines in Japan recommend 5 programs. In addition to cervical, breast, and colorectal cancer screening, stomach cancer and lung cancer screening programs are also recommended. Those 5 screening programs are recommended from the Ministry of Health, Labor and Welfare Japan as cancer control programs. Screening programs are provided by municipalities based on guidelines of the ministry. Before 1998, only 5 cancer screening programs recommended by the ministry were provided in all municipalities according to the law. Main body of screening provision at the time was the ministry. However, as of 1998, with the change of the framework of screening provision, municipalities became the main body. With this change, each municipality became to be responsible to decide the programs to conduct. As a result, many programs other than the 5 recommended programs became prevalent in most of municipalities. More than 80% of the municipalities thereafter have conducted screening programs which are not recommended by the guidelines. To investigate the reasons for introduction of screening programs without recommendation, we performed questionnaire survey. The survey revealed that even the expert on cancer screening misunderstood the endpoints of screening efficacy. Experts of the Academic Society on Cancer Screening answered that high cancer detection rate of screening tests is the reason to conduct screening programs not recommended by the guidelines. This means that they think cancer detection rate can be an endpoint evaluating screening efficacy, and they do not understand the aim of screening. Among the 4 aims of screening programs, those of the cancer screening programs are firstly to reduce mortality and in some cases to reduce incidence. Therefore, the endpoint of the program efficacy is mortality or incidence. It goes without saying that understanding on basic points of screening, such as the endpoint of screening, have to be shared among persons who are involved in screening. Wilson and Jung's principles gave the essential knowledge on all aspects of screening and have been known internationally. However, in Japan, the principles are scarcely known still now. Modified criteria of Wilson-Jungers define the essential requirement for the program to be conducted. The evidence needed is evidence of mortality reduction or incidence reduction demonstrated by RCTs of high quality. As a reason why knowledge on principles are lacking in Japan, a main one is probably the absence of textbooks on screening in Japan. Under such condition, we translated WHO materials of Wilson-Jungner paper and a short guide to screening programs into a Japanese and published translation under the permission from the WHO recently. This is an illustration of the structure of screening and harms as well as the benefits from screening. And this provides just basic knowledge, but appears to be very informative, even to Japanese experts, due to lack of good materials as textbooks. Particularly, contents explaining harms from screening have not been available until very recently in Japan. It is not well recognized that even in cases of true positives, not only benefits, but also harms, such as overdiagnosis, can be brought about. Overdiagnosis is the detection of cancer by screening, which cancer never harms the individuals in their lifetime. Overdiagnosis is now well understood internationally, but its knowledge is scarcely shared in Japan. And this figure may be of help in understanding overdiagnosis. In a healthy asymptomatic population, there should be a few preclinical cancer subjects. After time passes, their cancers grow and become symptomatic or clinical cancers. Other than such cancers, there can be cancer-bearing subjects whose cancers remain preclinical and never grow to a symptomatic stage. Such cancers do no harm to individuals. They never emerge as cancer patients in the absence of screening. However, once screening is done, they are screen detected and undergo unnecessary treatment, which is nothing but harm. With the next few slides, I will talk about thyroid cancer screening. This is a summary of recommendation on thyroid cancer screening by U.S. Preventive Services Task Force. Recommendation level is D, that is, do not screen for thyroid cancer. As to the evidence, evidence of efficacy is lacking, and even findings estimating the accuracy of a screening test is inadequate. So as a result, harms should outweigh the benefits. So the recommendation was D. Once after thyroid cancer screening is performed, incidence of thyroid cancer seemingly increases. In Korea, thyroid cancer screening using ultrasonography increased about the same time just after the National Breast Cancer Screening Program was implemented. Ultrasonography was not recommended as a breast screening test, but was very frequently done as additional test for breast screening. Next scan was passively performed. As a result, approximately 15-fold increase in incidence was observed in 10 years, whereas mortality remained unchanged. The gap between the two curves is attributable to overdiagnosis. Higher the screening rate, the more the degree of increase in incidence was observed. After the nuclear accident in Fukushima in Japan, thyroid screening targeting children has been being performed. Those who promote screening seem to believe blindly that screen-detected cancer must something be related to radiation exposure. However, it is well known that even among children, there is a pool of subclinical thyroid cancer. IAC in Lyon concluded in their report that screen-detected cases in Fukushima are suggested to be those subclinical prevalent cases rather than radiation-induced cancers. This means many overdiagnosed thyroid cancers have been generated through screening. We have experience of good lesson of overdiagnosis in the past in Japan. It is neuroblastoma screening for infants using urinary catecholamine test. Neuroblastoma is a neoplasm of a unique biological feature, and spontaneous regression of tumor is often observed. The program was conducted in 1985 without evidence on all infants aged 6 months. Up to 90% of the infants participated. And the program was halted in 2003 by the government decision because no mortality reduction was observed despite marked increase in incidence after start of the program. To review the process until the halt of this screening program may be of help in understanding what those who promote screening without evidence think about the screening. After neuroblastoma screening was started in 1985, the incidence among 0-year-old infants increased remarkably, and then followed by an abrupt fall in incidence after halt of the program in 2004. On the other hand, mortality remained stably low. No increase after the halt of screening was observed. This slide shows number of reported events of complication by treatment. Of those whose data could be followed, among 1,226 or 1,025 cases who underwent surgery or chemotherapy, 132 or 49 had complication, and among them 8 or 10 died of complication. In the absence of screening, these deaths from complication might not have been occurred or could have been avoided. Based on these findings and the lack of evidence of the program, this program was halted. Corresponding Academic Society of Neuroblastoma Screening announced the statements against the decision of halt of the screening by the ministry. They insisted that the screening program should not be halted until the suggested efficacy by the observational studies be demonstrated to be false. We cannot find any serious concern about harms from overdiagnosis in their statement. The principle that strong evidence is vital to evaluate screening efficacy is completely ignored. With the evidence-based approach, screening programs should be judged as invalid until the evidence is demonstrated. Such disregard of evidence seems to be similar to the case of uncritical implementation of thyroid cancer screening. The problem of overdiagnosis is becoming a more and more critical issue for some cancer screening programs. Particularly, a huge amount of overdiagnosis is generated through thyroid screening, is the most serious one. Incidence of thyroid cancer is seemingly increasing in many countries. This phenomenon is probably due to an increase in unnecessary screening tests performed as private screening and in clinical setting. To raise awareness toward overdiagnosis is most important issue. The only way to prevent overdiagnosis right now is to stop screening for thyroid cancer. Thank you very much for your attention.